So we are going to talk about respiratory acidosis today. As we discussed earlier, the pH can change only if this ratio of bicarbonate and PCO2 changes. That is the only way pH can alter. If there is alteration of the ratio as encircled. Now, acidosis, fall in pH can occur either if numerator of this ratio decreases or if the denominator of the ratio increases. In both the cases, the pH will fall and the condition would be called acidosis. Whenever there is primary fall in the bicarbonate ions, that time we call it metabolic acidosis. And in case of respiratory acidosis, the primary defect is rise in the partial pressure of the carbon dioxide. Now, how that can occur? What are the causes? Causes may be innumerable. I will just summarize a few. Hypoventilation is the major defect that can occur because of any airway obstruction in the bronchi or the bronchioles, etc. That can occur in asthma or in COPD, chronic obstructive pulmonary diseases. Then there may be some diseases in the lung, pulmonary diseases. Commonest one, for example, pneumonia. Then thoracic disease in the rib cage, if there is some problem, scoliosis, kyphoscoliosis, bending of the spine, flail chest, etc. Then neuromuscular disorders that may also lead to hypoventilation and buildup of the carbon dioxide partial pressure. That can occur neuromuscular disorder, for example, in poliomyelitis or in tetanus. Then excessive use of sedatives, general anesthesia, they are known causes of hypoventilation. And when PCO2 rises, I repeat, the ratio falls. And the fall in the ratio leads to fall in the pH because this ratio is the only variable portion of the equation, as you can see. Laboratory results, of course, pH fall, then PCO2 rise, bicarbonate concentration, initial phases, it will be normal or maybe at best mildly elevated. So what are the compensatory mechanisms? Now, one point which is of importance, you must bear in mind, if you saw in metabolic alkalosis, metabolic acidosis, the primary defect was in bicarbonate concentration in the numerator. तो compensation कैसे हुआ था? By decreasing partial pressure of carbon dioxide, by washing out carbon dioxide. So lungs played an important role by causing hyperventilation, kusumul breathing, for example. So in contrast to metabolic acidosis, where lungs played an important compensatory role, here the primary defect is in the lungs or in the airways, etc. So, of course, lungs cannot be expected to play any compensatory role. The compensation mainly comes from renal mechanism, although RBCs also play a supplementary role, a minor role. तो पर्पस अब क्या है? Purpose of compensation is to elevate the bicarbonate concentration, and kidneys play important role here. Kidneys, they ensure that any bicarbonate which is filtered at the glomerular level, that is effectively reabsorbed. This is a diagrammatic representation. This is glomerulus. This is a tubular cell. And on the left side of it, this is, we can say, lumen, like this I have represented. Now, bicarbonate, whatsoever is filtered, it has to be reabsorbed very efficiently, very effectively. So now we are going to see how kidneys help in that. Now PCO2 बड़ा हुआ है. So therefore, more CO2 will be available for carbonic anhydrase reaction occurring in the tubular cell, resulting in generation of carbonic acid, which dissociate by the same enzyme into H plus hydrogen ions and bicarbonates anions. H plus moves into the tubular lumen, combines with bicarbonate ion, giving rise to H2CO3, which again by reversal of this reaction forms carbon dioxide and water, and carbon dioxide diffuses into the tubular cells and again participating in the same cycle of reaction. So a vicious cycle is being formed, but the net result is the bicarbonate is not getting eliminated into the urine. It has been reabsorbed, although indirectly, in form of carbon dioxide. So this mechanism we call bicarbonate reabsorption by the renal tubular cell. There is one more also. Have a look at this reaction, the second reaction. Equimolar, H plus जितना form होगा, equimolar concentration of bicarbonate is also getting produced. And this bicarbonate now, it will move into the extracellular fluid, so thereby elevating the bicarbonate concentration in the blood also. So we can summarize that there are two ways in which kidneys are participating. Kidneys are elevating the bicarbonate concentration first by absorption. Whatever bicarbonate is getting filtered is absorbed. And second is bicarbonate generation, new bicarbonate generation. So this is also called absorption, is also called reclamation and bicarbonate generation. So this carbonic anhydrase mechanism operates in RBCs also. Fine tuning, slight, bicarbonate उसी तरह से generate होता है. So the purpose has been solved by carbon dioxide was rising, compensatory mechanism, bicarbonate also rises. So in the chronic cases of respiratory acidosis or in the compensatory cases, we can say that the pH is normal or near normal. Then PCO2, that is still high, but bicarbonate is also high in the compensated cases. That's how it differs from uncompensated cases. वहां पर bicarbonate high नहीं होता. And of course, kidneys, they take time compared to lungs, pulmonary. Lung का जो role है, that is instantaneous. Buffers also act instantaneously. There are three lines of defense: buffer, lungs, and kidneys. The first two, they act almost instantaneously, but the renal mechanism, they take time, 2 to 3 days. So that's all about. So we have discussed about basic defect, biochemical findings, causes, and compensation, the renal compensation. Thank you so much.